Thanks, Peter. So following this nice talk about imaging biomarkers, this is going to be a talk that focuses on circulating on blood-based biomarkers, but again, thinking about some of the same kinds of questions that were considered there. So particularly think about what's the benefit of adding novel or emerging biomarkers to standard cardiovascular risk prediction tools, and how can we do better at cardiovascular risk prediction? And that's prompted perhaps by the fact that we know that there are many cardiovascular risk scores out there. In fact, I think someone recently did a systematic review and came up with 100 different proposed cardiovascular risk scores. And even the commonly used ones have a wide variety of different risk factors that can be used in them. So we really wanted to try and examine what is the utility of using these different risk scores, given there are many different guidelines and many different scores out there. And compared to some of the very elegant biology that we've heard about earlier on, some of the very neat functional experiments, for example, this is really a talk that's really about brute force. So trying to amass evidence to provide some more definitive answers that can perhaps inform some of these guidelines. So we're particularly focusing here on a large collaboration we've put together, including many collaborators in this room, such as Willy and his Reykjavik study that we're going to hear about shortly. But we put together a collaboration with some 135 prospective studies of general populations, more than 2.5 million individuals, about 15.5 million person years at risk, and many studies with a follow-up more than 10 years. So we can think about doing at least 10-year cardiovascular risk prediction. And in total, there's some 60,000 incident non-fatal CVD outcomes. And you can see from the countries here highlighted in red that, again, there's a relatively global distribution, although obviously a lot of missing areas from these studies. So I'll talk initially about looking at lipid-related markers. We can touch, as Stefan did, on inflammation markers, and then if we have time, perhaps think about some other less well-known biomarkers. So we've addressed two areas in relation to lipid markers, mainly on the basis of questions prompted by different guidelines. So we can see here two different guidelines that had suggested perhaps that instead of the common way of measuring cardiovascular risk by using total cholesterol and HDL cholesterol, perhaps we could use apolipoproteins such as ApoB or ApoA1. But actually, other people suggesting that using more advanced lipid measures to try and improve predictive capacity, well, there just wasn't the evidence. So we set about trying to address these questions. So this slide looks again at the C-index, so a measure of risk discrimination, and thinks about what happens if we try and replace conventional lipids, and by this we mean total cholesterol and HDL cholesterol, in a cardiovascular risk prediction model. And what we can see from this slide is that we tried a variety of different lipid measures, either as ratios or as linear combinations. And what we saw is that actually when we took out total cholesterol and HDL cholesterol and replaced them with these measures, we always worsened risk prediction. So there was no real evidence from these 150,000 or so people from 36 prospective studies who had these available data to suggest that we should think about replacing the standard risk scores with different measures of lipids, at least on the basis of discrimination. So, of course, there are also many suggestions by different bodies that we should be adding more fractions. We should add maybe ApoB on top of HDL cholesterol and total cholesterol. We should maybe add lipoprotein a because we know that that's reasonably strongly associated with cardiovascular disease risk. We should add some even more novel risk factors such as Lp(PLA2), and at least in what was suggested as asymptomatic intermediate risk individuals, there might be some benefit of measuring these markers. So again, we tried to do a similar thing, take a standard risk model with traditional cardiovascular risk factors and see what happens when we add in other lipids or lipoproteins, again using these same 36 studies in about 150,000 people. And well, we can see here that we certainly don't do any worse when we add in these fractions. And actually in a couple of cases, so at the bottom, Lp(PLA2) mass and lipoprotein a, we actually shift our C-index up slightly. So from average combined values, something like 0.75, we can shift up by a very, very small amount here. So we can see something like 0.2% added, similar to the imaging biomarkers we heard about. that tells us maybe there's some improvement in discrimination, but doesn't necessarily tell us about the full picture about the utility of these markers. So we moved on to think about CVD risk classification. And so thinking here about 10-year risk, so for studies that had 10 years or more of follow-up, could we classify people into standard groups of low risk, so lower than 10% risk of a cardiovascular disease event, intermediate risk, 10 to 20%, or greater than 20%, the high-risk group. And we can calculate these standard measures, the net reclassification index. But what we actually saw for these markers, whether it was the apolipoproteins or Lp(PLA2) or lipoprotein(a), there was little benefit overall in transferring people to the right groups. So we were actually, even though we were shifting people, so 2 or 3% for these markers, we weren't necessarily shifting cases much better to higher risk groups or controls, people who didn't have events, to lower risk groups. So maybe on the basis of that, we'd say, well, actually, we're not doing a great job here of moving people around. We actually wanted to take this further and say, well, actually, the suggestions here weren't that we would necessarily add these things into risk scores that were measured on everybody and therefore change which categories people were going in, but actually we might implement slightly different sort of screening strategies. So we might want to measure these things just in the intermediate risk group, because just adding in something that's going to give us a slight improvement in risk prediction probably isn't going to change much about the people in the low risk group or the people in the high risk group. So we tried to do some clinical modelling to try and put into perspective what would happen if we added in these risk factors to our scores by just measuring them in the intermediate risk group. So we took a theoretical population of 100,000 people and said on the basis of the studies we were using, how would these people be divided into our risk groups? And we can see that the vast majority, of course, will be in the low risk group, lower than 10%. There'll be some 15,500 people in the intermediate risk group, and then a small number, some 9,000 in the high risk group. So according to standard guidelines then that are widely implemented, we assume that, well, actually in the low risk group, we're going to do nothing with those people. They're low risk. Okay, we know that the vast majority of the cardiovascular events will occur in that group because that's where the majority of people are, but we're not going to do anything about those people now. We're going to take the high-risk group and assume they're treated, and then we're going to be left with this intermediate risk group where we're just not sure what we should do. So by the time we implement guidelines such as, for example, treating people who have diabetes with statins or take out people who are already allocated to statins, we end up with a group of about 13,500 people who are in this intermediate, currently kind of unknown risk group. So we said, what happened if we were to measure lipoprotein(a) in those people? Rather than looking at the whole net reclassification index, let's just look what happens at those people. Well, of course, the majority stay in the middle group, so we've gone from 13,500 down to about 12,000 in this group. We've been able to reclassify about 1,000 people down to low risk, and then we've been able to move about 555 people up to the high risk group. We can say, well, that's well and good, but what would we actually do then? What would we actually do with those people? Well, we can see how many cardiovascular events we would expect to happen in those groups. Again, because there's so many people and still in the intermediate risk group, there'd be some 15 or 1,600 cardiovascular events here. But there's actually 86 events that were predicted to happen in these people who we've now reclassified upwards. So if we assume that on average we would give these people statins and they would take statins, and that on average we have about a 20% reduction in risk for people who take statins, well, we suggested that actually using this measurement we could prevent about 17, i.e. 20% of these 86 cardiovascular events occurring over the next 10 years. So by screening these 13,000 people with lipoprotein(a), that means that we could prevent approximately 1 extra CVD outcome for every 800 screened. The last point that Stefan mentioned as a way to evaluate these markers, of course, would be cost effectiveness, which is a step that we haven't yet done. So we can argue about whether or not we think preventing 1 extra CVD outcome for every 800 screened would be useful. But we've been basically trying to think about different ways of modelling this risk prediction. So we could argue that clearly there could be some modest improvement if we were to go out and identify these people and measure lipoprotein(a), but we really need to think about the setting that we're going to do this in before we decide that it's a good thing to do. We also heard in the last talk how it's important to actually go out and test these in trials of doing this, and of course this hasn't yet been done. I guess the final thing to say might be that, well, what we're assuming here is that we already have good ways of reducing cardiovascular risk. In this case, we modeled statins, and of course we don't yet have effective drugs to lower lipoprotein a, which have been proven to be effective in reducing cardiovascular disease risk. But of course that could be modeled into this in the future if that becomes the case. By comparison with the other markers, so for example ApoB and ApoA1, we saw that they had much lower prospects for improving risk prediction, and that actually we'd need to screen something like 4,500 people to prevent one cardiovascular disease outcome over 10 years. So clearly likely to be much less improvement in the cost effectiveness, albeit with cheaper things to measure. So maybe turning away now from lipids or things that are related to conventional risk factors and thinking about inflammation. Again, there's been a lot of debate about the links between inflammation and cardiovascular disease, and although we know that something like C-reactive protein, which is a good marker of low-grade inflammation, as a strong acute phase reactant, there's been a lot of debate about whether it could improve risk prediction. Well, we've suggested through genetic work that I'm not going to talk about today that actually it's probably not a good causal factor, but a lot of studies have suggested that actually it can improve cardiovascular risk prediction. And again, there's been statements suggesting here the American Heart Association guidelines in 2010 saying, well, it might be a good thing to do in these intermediate risk individuals. So we set about doing the similar kind of thing, so taking our large global collaboration of all these prospective studies and looking at the studies that had measured C-reactive protein at baseline so that we could see what the improvement, if any, in risk prediction was. And here we tried to benchmark this measure. So again, we're looking here at the C-index, so improvements in risk discrimination. And we wanted to say, well, we might improve risk prediction by adding in C-reactive protein, but how does that compare to something that's, say, already in our model? So what we're looking at here is compared to a reference group of a predictive model that doesn't include lipids, what happens when we add in first total cholesterol, then total and HDL cholesterol, and then CRP on top. And what we can see is when we compare the C-index to the previous scores, well, actually adding total cholesterol has about 0.4% improvement, adding in HDL on top of that a further 0.5%, and adding in CRP a further 0.4%. So we can see these are very small changes in the C-index that occur. Again, if you benchmark this by saying we're somewhere around 0.75 overall, but actually the effect of adding in CRP to our discrimination model is pretty much the same as adding in total cholesterol or HDL cholesterol, things that we already routinely include in these models. Again, we can look at the overall net reclassification index, so thinking about our 3 risk categories and how do people move. And actually this time we see a small improvement, so a 1.5% overall net reclassification index improvement, because we're doing slightly better on the controls in terms of down-weighting their risk, and actually reasonably well on the cases. We're actually moving 375 cases up and only 275 cases down. So again, this time we've got a marker where we've got a suggestion from the discrimination that there's a small but beneficial improvement, and this time also from the risk classification. So again, we tried to do a similar thing with our risk modeling, again, dividing people into the 3 groups. So slightly different numbers because we're working with slightly different sets of studies and risk factors. But we end up here with about 13,000 again in our intermediate risk group. So out of our theoretical 100,000, these are the people who we'd have to then take further steps, this time of measuring C-reactive protein. And again, we can see that we would divide people differently. We would reclassify people across the different groups. And again, we'd still end up with events in the low risk group, the majority in the intermediate risk group, but this time about 150 cardiovascular disease events in the high risk group. So this time suggesting that we could maybe prevent 30 extra CVD outcomes over the next 10 years, or out of the 13,000 originally measured, we could prevent 1 extra outcome, this time for about every 440 individuals screened. And again, we haven't yet worked through the cost effectiveness of this particular measure, but again, it seems like depending upon your setting, there may be some value in measuring C-reactive protein in the intermediate risk group, albeit at the cost of having to do additional measures on a sizable portion of people. People had suggested other inflammatory markers. I think C-reactive protein was definitely the most hotly debated, but we looked at adding in different inflammatory markers that were available in some of the same studies, broadly similar in terms of risk discrimination, so whether you use C-reactive protein or fibrinogen, albumin, leukocyte count, all slight increases in risk discrimination. A slide I haven't included, but might be worthy of note, we touched earlier on the idea of stratified medicine. And there's a suggestion from these analyses of C-reactive protein that actually this effect was seen in men but not in women. Now we're a bit cautious about this finding because we really can't explain it, and it hasn't yet been replicated in other data sets. But again, this might be a suggestion where we might actually measure certain risk factors in certain individuals. Now, of course, we don't think CRP is a causal factor, so we might not be wanting to use different treatments in different individuals. But again, we might be thinking about treating people differently, this time in terms of what risk prediction metrics we use on them. So to summarize this area of our work, well, although the currently used risk scores don't differ that widely in performance, they only provide maybe relatively moderate degrees of predictive accuracy, and maybe available novel or emerging biomarkers can provide some improvement, albeit quite small. There's a suggestion that other emerging biomarkers, and perhaps we might in future think more towards down the omics pathways rather than single biomarkers that we know very well, that some of these uncorrelated biomarkers such as NT-proBNP might provide more improvement, but we're going to really need more evidence for those. And really we think that before going ahead and deciding on new risk scores or guidelines that suggest we should measure new things, that we really need to look at these in reliable data sets and to check the accuracy, particularly think about the cost effectiveness, the practicability, acceptability and sustainability of these. And so I've really touched here just on an area of work where we're thinking about how do we actually look at cardiovascular risk scores and how do we improve them in terms of things like discrimination, reclassification, thinking about the clinical modelling. We actually have another collaboration, the EPIC-CVD collaboration, working with Ole and Peter and colleagues here in Malmö, as well as 10 other European countries, to take a step back and think about the bigger picture of cardiovascular risk screening. So some of that might be about thinking about different types of scores. So we've seen about more detailed risk scores, but actually might it be more cost effective, given the very small benefits of measuring all these new markers, to have much more simple risk scores. So maybe risk scores that don't include blood-based biomarkers, and that they could actually do almost as well and therefore be more cost effective. We're also thinking about different screening strategies. So I've already highlighted the idea that we might do an initial screen to get people into different risk categories and then do further measurements by recalling subsets of these individuals. We're also trying to think about what other factors should go into screening strategies. So for example, in the UK, we currently have the NHS Health Check, which aims to invite people at a certain age for cardiovascular risk screening. But is that the optimal way to do these things? We're not sure. How about behavior change? We've talked about the fact that we have medication we can use, but can we actually use people's cardiovascular risk prediction and different kinds of scores to actually motivate people to change their behavior? So are there certain kinds of things? We heard a lot about diet earlier on. Could we use diet in risk scores to actually motivate people to change their behavior? Time frame is one that we're also trying to think about, perhaps because of the studies we have available and perhaps because of the traditional metrics for risk prediction. We tend to think about 10-year time frames, but actually it's not really clear, particularly when we think about things like genetic markers and adding those into risk scores, whether 10-year risk prediction is the best metric here. So thinking about ways that we can extend that. And also thinking about outcome definition here. So I've been talking about a very heterogeneous definition here of cardiovascular disease, so including heart attacks, strokes, fatal coronary heart disease. But when we look at each of these markers, we know that there's differences in the predictive ability of each of these. So, for example, blood pressure predicts much more strongly on stroke, whereas, say, the apolipoproteins much more on coronary heart disease. So should we be thinking about disaggregating? Or actually, can we actually do better in terms of cost effectiveness by thinking about aggregating? So one of the next papers that we hope to publish from the Emerging Risk Factors collaboration thinks about what's the cost effectiveness of a screening strategy that not only tries to improve cardiovascular risk prediction by measuring markers of glycemia, but what's the additional benefit by identifying individuals who are diabetic in the population. how can we use simple measures to actually achieve both aims. I'd like to just acknowledge there the enormous number of people who've been involved in that work, particularly with the Emerging Risk Factors collaborators who provided data from their 135 prospective studies, and all the colleagues at the Cardiovascular Epidemiology Unit in Cambridge in the UK who've actually built the study and done these analyses, and of course the major funders, particularly the British Heart Foundation. Thank you.